At cardiothoracic surgery at General Hospital, Sri Lanka, and Royal Brompton Hospital, UK, and Hafield Trust, NHS. His special interests are coronary surgery and mitral valve repair. Go to you, sir.
So why deep sternal wound infection is very important? Because we all talk for days and days why this cardiothoracic surgery is losing its glory. Because people are scared about sternal wound and pain and all the complications related to that. So, to start with, though the incidence is very low, that's in high volume centers, with state-of-art centers it's around 0.8%. But in globally it comes to around 6% of the problem. So, being small, why should we worry so much? It is a catastrophic complications, and it's a blow to the surgeon's pride. Where you operate on patient leave good heart, but another problem with the chest. So, in addition, it causes the problem of prolonged hospital stay, long-term antibiotics, and multiple surgical procedures, and higher mortality, morbidity, and increased patient suffering and cost to the patient as well as to the system we are working. So, in the literature, evidence says that in acute conditions, the mortality range is from 10 to 40%, with very high cost burden to the patient as well as the healthcare system. In addition, we can witness there a person who developed the mediastinitis showing the lower survival rate compared to the adjusted to the risk factors, other risk factors. So, the deep sternal wound infection defined by the Center for Disease Control is an infection that occurs within 90 days of soft tissues, deep soft tissues and cavities and bone, and even with at least one of the following: purulent discharge from the incision, spontaneous dehiscence, and deliberate opening on suspicion by surgeon, and the cultures taken are positive. Additionally, if there culture is not done, if there is evidence of fever, high spikes, and local pain and tenderness disproportionate to the duration of the operation, and abscess and other evidence of infection detected on direct examination or during procedures and during imaging studies such as X-rays, CT, and ultrasound scan. So, what are the risk factors for patients to develop the sternal wound infections? All the patients higher chance, and gender females are higher. But particularly studies that females not shown, but obesity, with high obesity is proportionately high incidence of infections, and all vascular disease. It can be triple vessel disease and peripheral vascular disease, all contribute to the increased incidence. And diabetes is independently, it's a very high risk for the patients. And COPD and congestive heart failure with recent myocardial infarctions and renal failure. And the surgeries performed on urgent and emergency surgeries prove high incidence of deep sternal wound infections. In addition to the procedure related to the infections, where the methods we are working is, are we stick to the strict sterile procedures and strict sterile environment, or skin preparations and use of bone wax and pedicle mammary artery graft versus the scalenize, and in cases of perioperative bleeding which needed high volume of red cells and platelet transfusions, and prolonged operative time and proficient times has a positive relationship. And external rewiring and use of vitriolic balloon pump and the delayed administration of prophylactic antibiotic. And in immediate post-operation, strong cough. Some studies say if they develop more than 300 mm mercury pressure inside, it causes shear forces that causes increased incidence of it. So how do we diagnose the high index of suspicions we should always have? Whenever we see the post-operative patient in the wards, we should always check for the things, whether the wounds are healed nicely, and redness, swellings, and any discharges, purulent discharge, or patient complaining of, never neglect the patient complaining of fever, or if the patient found to be slow or no recovery, we must be very looking for. And in addition, we should look for the blood test and looking for the high rising inflammatory markers like white cell counts, CRP, and even procalcitonin levels. And in that conditions, when you have any suspicions, we have to go in early wound opening and look for the things, and bacterial sampling and assessment is very important. And then appropriate radiology analysis with X-ray, CT, and then ultrasound scan if possible. So management, there is no consensus of definitive protocol of care here. It is preferable to have a multidisciplinary approach involving microbiologists, intensivists, and radiologists, and our cardiothoracic and plastic surgeons along with our cardiologists is very important. So how do we manage these patients? It contains in 3 stages. One is infection control, and then we go for a debris removal and drain the wound and control the progression, wound reconstruction. So infection control, mainly we are concentrate on what are the, we should know about before thinking about control, what are the common organisms which involved in the Western literature, and as far as our Sri Lankan literature says, Staph aureus and epididymis account for 60% of the infections, while gram-negative bacilli come to 5 to 25%, while mixed growth account for, and fungus in few cases, and sometimes mixed fungus and bacterial cultures as well. So it's common in China as well. There's a 15 years study they found around same mollusk scale. So how will we control? That we will get the culture report with 2-3 days after that. But before that, we should consider broad spectrum empirical antibiotic until we get the real culture to treat the condition. So when we go further, the disease control and progression, we should know how to classify the wound. As usual, there's no consensus. So many people came out, Paolo and Richard Schmidt, and everybody called timing of infection and clinical finding and timing of infection with risk factors, and then we have considered the degree of bone destruction and the bone stock available, as well as reconstruction. Before that, what are the procedures we are going to do? So we defined the disease, and later part in 2020, the plastic surgeons, they summarized previous all together to make a consensus. We have type 1 wound, where deep sternal wounds infection reaching the sternum without sternal stability. And type 2 wounds, unstable, but there's no infection. But type 3, deep sternal wound infection, where we have sternum stay unstable with minor tissue loss or even less bone loss. But type 4, it's a severe condition where we get the deep sternal infection, mediastinitis, and bone loss is more than 50%. So where, depending on the level, we do the surgical debridement and negative wound therapy, and followed by wound revision and direct closure or fascial closure. And even latter part, we consider the flaps. So this is a flow chart where we can easily identify deep sternal without good structure, early debridement, and contaminated wound, clean it with bridge or end back therapy. Then clean wound, we have, depend on the soft tissue damage, we can consider the closure. So then average small defects, we can escape with the closure ourselves with the bilateral pectoral advancement or even skin closures. And average to large defects, then we need, it depends on, because our patient cohort is different, because we have harvested the mammary artery where we use the flap usually from the rectus abdominis. So with that thing, we can, and if the extensive and defect, consider that latimus dorsi or commental flap. Right. So in our conditions, where we are being a poor country, we should think about the prevention is always better than all the expenses and problems. So how are we going to prevent the infection? First thing, we should properly select the patient, and strict pre-operative optimization is mandatory. And meticulous disinfection and compliance with sterile principles in the theatre environment. And then we have to think about topical antibiotic, if possible, vancomycin paste. I think we don't have in our setup, but we can have it. It's not very expensive. And prophylactic antibiotic and nasal prophylaxis on time. And adapting hybrid sternal closure techniques in high-risk patients. For example, if an obese patient comes, we can think about plating or even electively, even fractures, bone fractures. When we close it, we can think of obstetric procedures. Avoidance of sternotomy, looking for alternative options. Now, we had so many lectures we had minimally invasive access operations. So whenever feasible, we can adapt to that, prevent the sternotomy itself, so we can prevent infection. So, how are we going to prevent that? And so we have a guideline from Association of American Thoracic Surgery. Guidelines give us overview on how to prevent it. It categorizes in the preoperative, intraoperative, and postoperative period. What are things we are going to adapt to prevent the infection? First thing, in the absence of documented negative culture for the staphylococcus colonization, routine prophylactic of topical methylzone is recommended for 5 days. And shower or bath using chlorhexidine or soap the day before and the day of surgery should be considered class 2 recommendation. And preoperative hypoalbuminemia, that's less than 2.5 milligram gram per deciliter, we should give the patient enteral feeding to increase the albumin status. And all distant and extrathoracic infections should be treated before the cardiac surgical procedure. It's a class 1 recommendation. And optimizing glycemic control is very important. If a patient found a HbA1c greater than 7.5 and serum glucose greater than 200 milligram deciliter, we should treat them. It's a class 1 recommendation. And use of continuous IV insulin to achieve or maintain postoperative glycemic control is very important to prevent the infection. And if you find a patient smoking, his cessation and aggressive on the toilet should be advocated, and we should advise the patient to stop smoking. It's a class 1 recommendation. And a beta-lactam antibiotic as a single antibiotic of choice in patients without MRSA colonization is recommended. It's a class 1. And patients who are considered beta-lactam or penicillin allergic or with proven suspected MRSA colonization, vancomycin recommended as a primary prophylactic antibiotic with additional gram-negative cover. It's a class 1 recommendation. It is recommended that administration of antibiotic coverage should be completed within 1 hour of the skin incision and start of surgery. And continuous infusion of insulin should be instituted, maintain glucose level 80 during the operative time. And topical antibiotics should be applied to the pathogensternum at the opening and at the closure. And bone wax should not be applied to the pathogensternum at any time. It's a class 3 recommendation. And scapular mammary artery dissection is recommended in patients diabetic and obese, or when we are thinking about bilateral internal memory for hospital. And closing sternum with figure of 8 technique is preferable over to normal closure techniques. And to closing sternum with multiple fractures, the Robicheck wave technique is known to prevent the dehiscence and wound infections. So class 2B, we can consider that. And closing sternum, rigid fixation or band plate may reduce the dehiscence wound infection in high-risk patients. And in the postoperative period, external chest support vest may limit the incidence of external dehiscence and infections, class 2B, so we can consider that. Appropriate prophylactic antibiotic should be continued postoperatively no longer than 48 hours. And continuous insulin in the ICU for 24 hours at least to maintain the glucose levels around 180. So, early days the practice was diluted iodine irrigation in the treatment of deep sternal wound infection and mediastinal arteries. It's not recommended, it should be avoided at any cost. And negative pressure wound therapy is recommended either as a destination or bridge prior to any surgical options in the postoperative mediastinal arteries. And use of muscular augmented flap in case of sternal instability and its insufficient form. And again, I must thank you for the association giving me this opportunity. Thank you very much.
Thank you, Siva. Any questions from the audience with regard to all the 3 talks?